I thought I would present some of the things that I've done to push the envelope. So some of these are things that are evolution for me, but I thought I would share with you. The first is going to be a double row labral repair. And when we consider some of the techniques that have been described for ideal anchor placement, it's always been get a bumper going and get the labral repair on the glenoid face, and this type of construct was bad. So get the anchor right on the edge and the margin. But this is all cartilage here, so how is the labrum really going to heal here? Look at all of this footprint that we spent time preparing. So in many ways, these single row repairs are not taking advantage of biology, and they're not quite anatomic. So we did a little project and we looked at what is the actual footprint, much like our rotator cuff repairs. And the footprint is large. A rotator cuff supraspinatus is about 12 to 14 millimeters of footprint medial to lateral. Look what it is. It's almost 10 millimeters for the labrum. And you can do a double row labral repair just like you do for a rotator cuff in almost the same exact fashion. And when we studied it in the lab, you get the typical results that we learned for rotator cuff. Single row repair, you don't really effectively get the footprint restored. Double row repair, you can really take advantage of it. So here's an example, bad quality tissue, the labrum's torn, and when we look at it from the top superior view looking down, all of this is glenoid footprint we could take advantage of. So we're going to put an anchor on the medial aspect, and then we're going to pass it through the capsulolabral complex here, and we'll do just like a rotator cuff. We can use a push lock and we can fix it. And another advantage is this is a knotless construct. So we don't have knot irritation, and we got footprint restoration, we have compression. This type of technique now lends itself perfectly to do a Bony Bankart, and Peter Millett has really emphasized this. And here's a patient of mine when I was kind of getting comfortable with the thought of doing a remplissage. I didn't have the right patient just yet. Well, here's a patient who came to see me, locked shoulder dislocation, older, was scheduled for a hemiarthroplasty by another surgeon, and I thought that was a little aggressive. So we decided to fix this arthroscopically, and you can see there's a big Hill-Sachs lesion here, and we're going to learn how to fix that. But there's this Bony Bankart. Well, we can take advantage of this Bony Bankart and we can fix it. And this patient doesn't need a Latarjet, she doesn't need a hemiarthroplasty. We can do a remplissage here, and I'm not going to go over a remplissage technique. I'm going to emphasize this. How do we fix a Bony Bankart? Well, one is the Bony Bankart has soft tissue of labrum stripped, inferior and superior. So let's fix that in a traditional way. But in this case, we're not going to tie that first inferior suture that's placed. We're going to leave the Bony Bankart very mobile. And this is what surgeons often ask me. If you're going to fix a Bony Bankart, I cannot get the suture to pass around the bony piece. It's just I can't get the passer to go around it. Well, the first trick is don't fix the bony piece and tether it anyway. Make it as mobile as possible. In fact, mobilize it so it can lift up on top of the glenoid. Then you can percutaneously place a passer, often a curved passer, that'll get underneath it, around it, and then you can get it onto the glenoid face, and you can do your suture shuttling. So you can see there's a little bit of challenge here getting it in the right position, and as you get used to it, letting it be mobile, you'll be able to get this passed much more easily. Okay, so we passed our sutures, and now just like before, we're going to retrieve and we're going to fix it with a push lock on the glenoid face, and we can get a nice Bony Bankart repair, and then we can go and finish up our remplissage. Here's another Bony Bankart. This one's big. Look at the size of the bone, and the bone quality is good. I don't like the feature of a suture technique where you can have sutures that are going to be on the articulation of the glenoid face. So if you have a sizable piece, it's amenable to a screw, and the glenoid bone loss set is really great for this because the cannulated system and the long K-wires and drills that you would use for a Latarjet can be used arthroscopically here. So you can introduce a guide pin, reduce your Bony Bankart, fix it provisionally with that guide pin, drill and insert your screw, 375, titanium partially threaded, get beautiful compression. You can restore this, and you don't have to open this and have difficulty with managing the subscap. Here's another interesting case that's a little bit, is a recent case that was something that I wanted to try. And look here, deep Hill-Sachs, a little bit short, some glenoid deficiency, young athlete. This would traditionally be a Latarjet or remplissage. When Arthrex developed these contoured osteochondral fresh plugs, it had great features for cartilage restoration, but they can also make up for some bone loss here. So this is the superior view of the Hill-Sachs. We've placed a pin, and now we're creating a 10 millimeter socket in preparation for an osteochondral graft. This is what it looks like. We can then deliver the osteochondral graft in one of the Oates delivery systems, and this is going through the infraspinatus, so we have to make a little bit of a pathway, viewing from the top, just like we'd be doing a remplissage. And now we can insert and correct bone loss with pre-contoured fresh osteochondral plugs. So we'll push that in, we'll tamp it into place, and we can get something with repeated plugs that can fill in that defect. And that may have some advantages for some of those really extensive shallow plugs, or the short ones that are really deep, that you may have a challenge getting the infraspinatus to really tino decent side. And so here's a anterior repair that goes along with that work in the back. This is what it looks like on x-ray. You can get a little silhouette of what those plugs look like. Here's the plugs here. So it is something that may be worthwhile in the future to develop even further. Now here's one more thing that I wanted to introduce. This is more of a indication, not a technique. This is a patient who had a total shoulder by one of my partners who then retired, and she fell and dislocated her total shoulder. And maybe her subscap was not working well, but she is still intact enough. And rather than let her live, she was having recurrent instability episodes, and do a reverse or do something that was big, we did an arthroscopy in the setting of a total shoulder, and we did a arthroscopic capsulorrhaphy. Nothing different than the techniques that you know. It just happens to be in the setting of a total shoulder replacement, where we can do very elegant imbrication, just like we might do in a patient who's had MDI. And as you know, total shoulder replacement, one of the complications is instability, much more common than, say, component loosening. So this is a woman who couldn't lift her arm without apprehension, and you can get a very nice result in that way.